Hello, everybody, and welcome to the latest episode of the Modern Medicine Podcast. Welcome. This is the place to be for 1 hour on everything that's happening in the world of medicine. I am your host, Dr. Dennis Teehan, MD, MPH of the Beth Israel Lahey Performance Network, and I'm here to give you all the insight on everything that you're hearing about in the news about your health so that you can stay healthy. Joining me, as always, is my friend, the man himself, Producer Dave Yaz. Producer Dave, how are you doing today?
Dr. Dennis, great to see you. Great to have you back in the studio. I know we got a jam-packed episode per usual.
We have
a great guest.
Awesome episode as usual. Some great stuff to get to. And as Producer Dave said, an awesome guest. This is going to be a special episode of the Modern Medicine Podcast because it's been a tough week a couple months really, for my family and I. We lost my father a few weeks ago to cancer. And I thought maybe it would be nice to dedicate an episode to him and to his memory. And joining me in that is his oncologist, Dr. Erin DeRose, someone who was absolutely wonderful to my father. So we're going to bring on the good doctor, introduce her, say hi, Dr. DeRose. How are you?
Good. How are you? Thanks for having me.
No, it's so wonderful to have you. And Dr. DeRose is a oncologist at the Beth Israel Needham Cancer Center, where I had never met her before as a professional, even though we practice just miles away from each other. And I'm a Beth Israel doctor and she's a Beth Israel doctor. Our paths had never crossed, but fate kind of brought us together with my father's medical situation. And she was absolutely wonderful to my father. And we're going to get into all that. But before we even go there, just want to give Dr. DeRose a little bit opportunity to tell us about her background and about the Cancer Center at Beth Israel Needham.
Yeah, so I, in terms of deciding to go into oncology, I think I didn't know that I wanted to do that right off the bat, or even go into medicine for that matter. I went to a liberal arts school in Colgate in Central New York, and had always been interested in the sciences and majored in molecular biology, and actually went directly to medical school out of college. But I didn't know from like a young age that I thought I wanted to be a doctor. I think that I always wanted to help people and had an interest in science, and it sort of led me to medical school. And while I was in my internal medicine rotation at SUNY Upstate in Syracuse, I happened to work with the chair of the Department of Medicine. That's who I was assigned to when I was on rotation. And he was an oncologist. And I think that was really the pivotal moment in me deciding to go into oncology, because he was just an incredible physician. And, we were on an inpatient service, and these weren't even his personal patients, but the relationship he had with the patients was just like nothing I had seen before. And we saw so many different diseases, from aplastic anemia to pancreatic cancer. I mean, I can remember the cases, in detail, and how much I learned during that rotation. And so I had some idea going into residency that I, had an interest in oncology. And now, more than 20 years ago, moved to Boston to start my residency, actually at Beth Israel, and ended up doing my fellowship there as well. And my initial interest was actually in metastatic melanoma and immunotherapy. But when it came to looking for jobs, I really realized, and being honest with myself, that I wanted to do patient care predominantly. And then I had an interest in a lot of things, and that I felt like a community practice was the right fit for me. And so I actually started at Beth Israel in Needham before the Cancer Center existed. Right out of fellowship, it was basically in one of the inpatient wards, and like out of a couple of the rooms on the second floor. And I was there for about 2 years, and then I felt like I really needed to kind of be with other oncologists to expand my expertise and expose myself to sort of other things. And so I went to Mount Auburn Hospital, where we had Harvard medical students and residents. And I was there for about 7 years before coming back to BI in Needham, which I've now been here for 6 years, which is hard to believe. But I came back because I really think it's a great place. I love working in the community. I'm lucky enough to, our medical director did residency and fellowship with me. And I just think she's a wonderful, Dr. Downey's a wonderful doctor as well. And I think it's so important to work with a team where you really have the same goals or on the same page. And, working in the community here outside of Boston really gives us the opportunity to have this really small center where I always say we really care for people rather than just treat people, and have this small group that's really all has the same goal to really do best by our patients, take really good care of them, get to know them, get to know their families, and really give them support through really difficult, a very difficult time in their lives, while still having access to Boston, right? Still having access to clinical trials, still having close connections with our colleagues in Boston because we've trained with many of them that are more subspecialized than we are, and giving patients access to, world-class care and clinical trials when, anytime that they're eligible for that. So it's really the best of both worlds. Yeah, I can say nothing but good things about working in the community. I think it's been really the best decision that I've made.
Well, I can tell you for sure that in terms of your objective of caring for the whole person, that you guys absolutely do that. And, Erin, I don't think that people really understand just how great the Cancer Center in Needham is, to be honest with you. And I think that when people, especially older or sicker people, are diagnosed with cancer, and these individuals are so vulnerable sometimes, and a lot of times it's really hard for them to get into Boston. And what I learned from my experience with the Cancer Center Needham is that, first of all, you guys can more or less do almost everything there, right in the community. The parking is free. It's easy to get to. It's accessible. It's not a total, you guys are busy, but it's not a total nut house like some of the downtown places are. And that whenever someone needs to be able to go downtown to get that, that second opinion or get that academic voice in, those options were always available to my father. So you just used the term, the best of both worlds. Can you talk a little bit about the best of both worlds approach, where you have this community based cancer center in the suburbs, and then also have the option of the academic medical center in the city?
Yeah. I mean, I think that having, trained in Boston and done my clinics there when I was a fellow, I mean, I would often think about how much it is, like how much patients have to go through just to get to the appointment, like to navigate Longwood, to park, to get up to the 9th floor, to do all of that when they're not feeling well. I mean, that's a huge thing. I mean, I hated commuting into Boston.
Right.
I can't imagine what it felt like to be like an older person who's on chemotherapy trying to navigate that. And I think that the nice thing about being in the community center is that you get to know, like, from the front desk staff to the nurses to, we have a dietitian, we have a social worker, a physical therapist, we have radiation on site. But it's very small. So you get to know pretty much every single person that works there. And then at the same time, when we have, either exhausted treatment options, or we know of other, new treatment options that are coming, down the pike, we have access to that because we partake in tumor boards. We're able to go to lectures, via Zoom. That's one good thing that came out of the pandemic is that really we have much more access without having to go downtown to all of these things that they offer because they're online. We can, attend meetings and do those things that we didn't have access to before.
So you're staying on the cutting edge.
Right, exactly. And so we're really, and we really have great relationships with our colleagues that work in Boston. Some of them I trained with, some of them I trained, and they're, but they have subspecialized. And I have to say, a lot of the people that decide to stay at Beth Israel in particular to do oncology, even though they're in sort of the bigger cancer center, the focus really still is really on the patient. I have to say that's often really, it's just kind of part of the culture. That's why I decided to do all my training there. And so they really go above and beyond. Like if I send an email to, someone who's even doing phase 1 trials or whatever, they answer me right away. They let me know if they think a patient would be a good candidate. They also communicate and say, these are the things that we have open right now. Do you have any patients that would be good for these trials? So it's really, it's an opportunity for patients to kind of know about these things without having sometimes even to need to go for a formal second opinion. Although I often send for second opinions, and I encourage people actually to get second opinions. We are lucky enough to live in a place where we have access to, world-class medicine. And, this is a person's life. And I think that they should be comfortable with whatever decision they make. I never take offense to people getting second opinions. I think they
Patients
should.
ask me that all the time. And I always say, look, the doctor just wants what's right for you. They don't care if they want you to get a second opinion. We all understand, and we've all been doing this long enough. So we understand our limitations. So please, by all means, get a second opinion. I can say firsthand, just from my family's experience with my father, that, the care you provided in Needham, it's intimate, it's excellent, it's personal, it's convenient. But, and my father's situation was like a perfect example where there were 2 or 3 times in his illness that he needed to go to Boston and get that sort of second opinion. And that was always there for him. And I think that was one of the things that just not only as a family member, but also as a physician, that I just found so impressive about the way things worked at the cancer center in Needham.
I think what we forget, because of where we work too, is the vast majority of people in this country receive their care in the community. Yeah. Right. And so, but we're so used to working in this very subspecialized academic area that we forget that. So when I say it's the best of both worlds, it really is, because you get the community feel, and yet we have such close access to Boston. Although patients sometimes act like I'm asking them to travel across the country when they go into Boston.
Right. I know the feeling.
Because there's a few things that we can't do in Needham. Like we don't have a PET scanner. A lot of hospitals don't have PET scanners. They have either mobile units or something like that. And there's certain certain more invasive procedures and things that we don't do in Needham because it's a small hospital. But generally, we can pretty much keep people in the community, or if they have to go in, briefly for something that we don't offer, we often bring them back and try to provide as much care as we can in the community.
Yeah. And I think too, and just as a Beth Israel doctor, I'm so excited about the Beth Israel and Dana Farber marriage that's kind of taking place. And I think that the best of both worlds thing we're talking about, I think that only is going to get better with Farber Hospital that they're building in Longwood, and just having really access to pretty much everything at our fingertips.
Yeah. And I think that it'll be a great thing for patients to get really the best inpatient care and with specialists that are taking care of them when they're in the hospital. So I think that's I'm excited about it. I don't know exactly what it will look like, but I think we'll have even more access to things. I think it will be a good thing.
Awesome. Agree 1,000%. I want to talk a little bit about my dad's situation and it, as it pertains to what I think are some of the larger topics in medicine right now, and the direction the field is headed. So for those that don't know, my father was diagnosed with stage 4 metastatic lung cancer, October 23, and he never smoked a cigarette in his life. Right. And we're seeing, and it's just unbelievable to me that happened, by the way, because he was so healthy his whole life. But, we're seeing more and more as doctors of these patients that never, ever touched tobacco and yet are getting lung cancer. And there are some hot topics in medicine around that I wanted to ask you. One of them is if you have thoughts about lung cancer screening for everyone. Right now, we do lung cancer screening in people that really have been ripping cigarettes for decades. That's what we are really screening. But there was just a paper in JAMA, December 25, that showed that there might be actually some benefit to screening everyone for lung cancer. So I don't know if you had thoughts about screening everyone for lung cancer.
Yeah. I mean, I've been thinking about this for a long time because I have to say, when I was at Mount Auburn, I did a lot of breast cancer. And when patients would get their simulation for breast radiation, they do a CAT scan. And there were many patients where we found lung nodules that were actually primary lung cancers in never smokers and younger women sometimes, that we wouldn't have otherwise found. And it's because the radiologist actually read all those CT scans.
Right.
And then I became involved in their pulmonary nodule clinic there. And so I was kind of doing both things. And so I've been thinking about that for a long time because we just saw it in practice, picking up these, early lung cancers. I think that there may be a place for it. I think the tricky thing is that, as you know, we'll pick up a lot of things that are nothing, and then that leads to more scans.
The so-called incidentaloma.
Right.
Yeah.
And
that's like half my job these days.
Right. No, I'm sure it is. I'm
Yeah.
sure it is because people go to the hospital, they get admitted
Right.
for something else, they get a scan, and then you're stuck
Right.
following. And so, and then we have to think of the long-term radiation exposure. I mean, the screening CTs that we do for lung cancer are low-dose screening CTs, so there's not
Right.
as much radiation exposure.
But there's still a good amount. I mean, that's a lot more than like an X-ray, or like an airline.
Right. And so over the long term, over years,
You're
right, we have to think about that piece too. But I think maybe we can be, maybe not everybody, but we can find some populations that maybe we should be screening at, X age or whatever. But I mean, I've definitely seen it. And then the other thing is really young people getting diagnosed with colon cancers. I mean,
Yeah. Yeah.
I've never seen anything like it,
It's
like I have
unbelievable.
recently.
You treat colon cancer too, right?
Yes.
Yeah.
Yes.
I mean, I'll tell you right now, I was just talking to the patient about this today. In fact, like I think within a few years, you're going to see the colonoscopy start at 40. Not, we just lowered it from 50 to 45. And the only thing I think the reason they haven't done it yet is because I don't know if we have the providers to handle it.
To do it.
I mean, that's the problem. The screening colonoscopies are like, I can tell you, we're booking out oftentimes 6, 9, 12 months, right? So, but I definitely think, I mean, the colon cancer is another big thing, but I mean, with the CAT scan for the chest, it's like, it's such a minefield because we pick up all these nodules. We don't know the significance of them. All I can say on this one, Erin, is I hope the robots save us. I really hope that AI
that might be the one that,
right. That somehow they can figure out who should be biopsied, who shouldn't be biopsied when we pick up these things, because we do, there is a downside to taking a picture of everything.
Right. But I mean, I'm definitely, like I said, we've thought about it. We actually thought about doing like a case series because we were picking up all these, lung cancers, but I have some bias, right? Because we want to, obviously we want to treat people. We want to find things early, but then we see the other side of it too. So
and it's harder sometimes to see the other side of it. I will say that some of these recommendations, the U.S. Preventive Service, I mean, I feel like sometimes they do focus a little bit too much on things like the larger picture and cost effectiveness and not enough on the patient. And that's sometimes, I do try to take some of those recommendations with a grain of salt. Let's talk a little bit about some of the things that we know cause lung cancer that have nothing to do with tobacco smoking. What are some of the other factors? Do you want to discuss that for people who maybe want to discuss this with their doctors? Okay, they weren't a smoker, but what are some of the things that might put people at higher risk?
Yeah, I mean, certainly people like firefighters, people that have had secondhand smoke exposure, for sure, other sort of asbestos exposure, sort of in their whatever jobs that they do. Family history actually of lung cancer. If you look at the ASCO guidelines for sort of who you screen, that is one of the things, and age, which obviously we can't do anything about that, but are all risk factors. Certainly smoking is the biggest risk factor.
Yep.
But then we do see these people that have been never smokers. I mean, they tend to be the patients that are never smokers, though, tend to have these certain mutations in their tumors,
right?
Like EGFR mutations. And that then we have targeted therapies for and generally have a better prognosis. But we're still not, when advanced, unfortunately, we're still not curing them of this. So,
Yeah. And the other big one is radon, right?
is radon, right. And that's on the list of screening people. If you've had radon exposure, that's on the sort of the ASCO guidelines for who you should screen with a chest CT.
Because my parents, I grew up in a kind of an older kind of turn of the century kind of colonial house with like a big stone basement. So, I've told my mother, I'm like, look, at some point I want to do a radon kit just to see where it is, because I think in my father's case, I wonder about that. I wonder about the secondhand smoke exposure. I mean, back in the 50s and 60s, and these are the people now that are in their 70s and 60s and getting kids. But back then, that generation, I mean, everybody was just smoking everywhere. Right. I mean, they all had a ton of secondhand smoke exposure. So when you tell me that 10 to 20% of cancer cases are in non-smokers, and I'm just thinking of all the secondhand smoke that these people probably inhaled in their life, especially when they're young and they're most vulnerable.
I mean, some of the older nurses would tell me the doctors would be smoking in the hospital. To even wrap your head around, I mean, I can't wrap my head around that.
Unbelievable.
But there had to be, there was a lot more exposure than there is.
Let's talk a little. You just hit on something called the EGFR mutation, and that's going to segue into our next topic, because one of the things, again, about my father's situation is, he was diagnosed with very advanced and serious disease. Unfortunately, it was really like a thunderclap. But the only good thing was that he had this mutation called the EGFR mutation. And, to me as a primary care doctor, EGFR made estimated glomerular filtration rate. I didn't know much about it until this happened to my dad. Right. But then I obviously learned about it. And this is a common mutation that we see in a smaller percentage of lung cancer cases, but the advantage and why you test for it is that, and what this is going to segue into is that people that have this mutation, this is a real target, like a target area for some of the newer cancer drugs. And in my father's case, I don't think 10 years ago, 20 years ago, he would have lived 3 months from where he was diagnosed. He lived 31 months, I think. And it was really because he had the EGFR mutation. He was able to take a smart drug that was a couple years old, Tagresso, that was targeted to his mutation. And that allowed him to do quite well for a long time.
Yeah. And I mean, I think so when I was in fellowship, which wasn't that long ago, 15 years or so ago, right. I mean, these drugs, the older generation of these EGFR drugs, which is epidermal growth factor receptor mutation targeted drugs, they were just starting to be used, and now we have newer generations of those drugs. And when I was in, fellowship, patients would get first line, platinum-based chemotherapy when they had metastatic disease. And if they progressed on that, which was sort of the best that we had, if they didn't have an EGFR mutation, then they went on to more chemotherapy, and their life expectancy was measured in months.
Yeah.
Usually. And I have, fellows now that I train now, and they've never really experienced that, right? We seldom even, I sometimes give second line chemotherapy, but now with immunotherapies that we have, or in cases of patients that have targetable mutations, there's not only EGFR mutations, there's other targetable mutations. And then patients that develop resistance to these EGFR targeted mutations, they develop certain resistance patterns in their tumor. Then they might be eligible for other targeted therapies. And so, life expectancy is then measured in years rather than months. It's still not long enough, right? It's never long enough. And we're still not curing it. I mean, the downside of these targeted therapies is that they eventually stop working. And so
kind of like antibiotics, right? I mean, it's the same kind of idea, right?
Right. So the tumor mutates. The tumor mutates, it figures out a way to grow around the mutation that you're targeting, and then you have to switch it up. And so I think that this changed a lot, but immunotherapy has changed a lot. So that's really the other big sort of category of therapies specific, not only for lung cancer, but many other different types of cancers, is immunotherapy. And so when I was, when I was a fellow and I was interested in melanoma, we use immunotherapy for. Chemotherapy doesn't work for it. But the initial immunotherapies were like interleukin-2, which I don't even know if you know much about that, but patients had to be admitted to the hospital. It was a very select group of patients that could even receive it. We basically made them septic. And, about a third responded, and a third of those patients went on to have a long-term response. Since then there's, PD-L1 inhibitors, there's, ipilimumab and other targeted therapies for not only melanoma, but kidney cancers and, other types of cancer and including lung cancer. And so we've come such a long way. I mean, so now it's more the norm.
Do you feel like we're at a point now where, like, it feels like, from my perspective, and I'm really not an expert in this, I'm a jack of all trades, master of none, but like, it feels like we're at this point where more and more of these cancers are being treated in newer, targeted, smart ways, and less in the older ways. We still have a long way to go, but do you think we're at like the precipice of like an era in the next 5, 10, 15 years where, targeted smart therapies are going to be mainstay, the majority of how we treat these diseases? At least,
I think we're really moving toward this. So if you look at, in terms of like the different cancer types, I think hematologic malignancies, we've seen a lot of advancement in those malignancies in particular. When I see a patient now with multiple myeloma, I try to explain to them, like, the problem that we have now is what do we give first? Like, what is the best treatment? Do we give you 4 drugs all at once? What is the best thing to do? Because we have so many options now. That's a good problem to have, because, not that long ago, we didn't have all of these things, right? And
totally different game for myeloma now.
Right,
totally.
Exactly.
Yeah.
And so, but now these immunotherapies, I think that, sort of the future, present and future, will be applying more of these immunotherapies and targeted therapies to solid tumors. So CAR T therapy that we're using for, lymphoma, myeloma, leukemias, which is basically a T cell therapy, where it stands for chimeric antigen receptor T cell therapy, where you basically genetically engineer the patient's own immune cells to recognize and destroy the cancer. But now, what we were doing initially is you collect the T cells through leukapheresis, and then you make in a lab, you target them to this CAR protein, and then you reinfuse them. But now there's going to be off the shelf, or there is off the shelf CAR T therapy.
It's amazing.
And I think they're going to be able to apply that to solid tumors. There's, and then there's BiTE therapy, which we're also giving. Again, a lot of these are still given as inpatient because there's these big immune reactions to them, but bispecific T cell engager therapies that we're giving. And then antibody-drug conjugates, where the antibody targets the cancer and brings the drug to the cancer cell. In addition to these other molecular therapies like Tagrisso and these other, targeted to specific mutations. So I really think we're present and future here. And then I think it's only going to get better. And then sort of figuring out, as these tumors change, how do we make the therapy better to deal with the pathology of the tumor itself when it changes. And so using things like CRISPR and like gene editing these T cells so that they can better directly attack the tumor cells. I think there's a lot of exciting things.
It's a really exciting time. The public health person in me, the one thing I think of when I hear all this, and I think we are at the precipice of like a crazy new era, but then, I think the 2 questions that they're going to come up as we get better and better at treating cancer is, one, who gets these treatments and who doesn't? Because that's a huge problem for everything we do. And you can look at something as simple as Ozempic, right? And how that has just become, a huge inequality thing in that. And then who pays for it? Again, look at Ozempic, a hugely beneficial drug, helps so many people, but it's also kind of taking down like the insurance payers one by one because no one can pay for it. So now we're going to take these super smart, probably super expensive therapies, and as they become more present and available, that's a great thing. It's also going to be a tremendous stress on our healthcare system.
Right. And a lot of these right now can only be given in sort of academic settings, right? But they're going to get better, right? We're going to eventually be able to give them in the community. But it's going to take expertise in giving them. They're expensive, like you said. So I think and then, like I said, a lot of the country gets their care in the community, right? So those people won't have access to that still.
Yeah. 100%. Exact. And then let's not even talk about internationally, right?
Right.
Where we can't even get like the measles vaccine to kids that need it, let alone,
Yep.
100,000 kids every year still die of measles. So now
Mhm.
we're going to take this super highly refined, engineered, sophisticated product. How are we going to get that to sub-Sahara Africa? How are we going to get that to Tibet? It's going to raise a lot of questions, but that's also a great problem to have. But at the end of the day, that it's better than what we've been the last 50 years. All right. One last question. And very quickly, because I've taken up almost half hour of your time and I know you're busy. I just want to ask about this because so many people come into my office and ask me about this, and I have to ask you about it.
Sure.
Direct to consumer blood tests for cancer screening. This is something you're hearing more and more of. I look at the data. I'm not really that impressed with what I see. I think it's a road to a lot of problems right now, but I'm curious if you have an opinion.
Yeah. So my personal opinion is I think that there's going to be a role for example, testing, circulating tumor DNA and things like that. But right now we don't know what to do with the results. And every time I do a test, and I tell my patients this too, we should know what we're going to do with the results of the test, right? What we're going to do with the outcome of the test. And the problem with these things are, so say you do a test, you find something. Well, then what do you do with it? Then you scan people. Then what if you don't find anything? Did you just cause anxiety? Is it false positive? Is it then do you check another test? Like, what do you do with the result?
Right.
And so until we know and we have sort of guidelines as to what to do with the information, I don't think it's a good idea.
Yeah, I agree. And, like I said, Cologuard now has a product. I have a lot of thoughts. We've talked about Cologuard on this podcast before with Stephen Rotman, who's at BI Needham. If you know him, gastrologist. I'm like, very, very skeptical. And I think patients don't really understand what Cologuard is and what it can do and what it can't do. But Cologuard now has a blood test. I forget, they call it something guard.
I've seen it advertised.
Yeah. And they're going right to consumers now. So I've had several patients come into my office for physicals and be like, hey, what do you think about this? And I'm like, I really don't know. My sense is it's not a good idea.
I mean, right now it's not a good idea. I think, they're doing studies on using circulating tumor DNA to follow patients. And I hope that that's actually going to be helpful so that we can cut down on the number of scans that we're doing for people that actually have, a known malignancy, right? I think there's going to be a use for it. And then maybe eventually we can use it for screening. I just don't think we're there yet. And it is a slippery slope and might lead to, it leads to a lot of anxiety. I think people never think about well, what if it's positive? And then we do all the workup and we don't find anything. Then you're just kind of living with that knowledge.
And one of the things I've learned, and I'm going to see if producer Dave is awake and if he wants to ask a question in a minute. But one of the things that I've learned over my years of practicing medicine, and I know you'll agree with this, is that not all suffering is death and disease. And the way we speak to people, the way we handle things, the anxiety we create or don't create. That's like psychological torture if we don't carry ourselves the right way. So, we have to think about, at the end of the day, everyone dies and everyone gets sick, but what happens in between? And how much do we torture people? They really have to think about that stuff. So
for sure.
Producer Dave, you got anything you want to ask Dr. DeRose? Are you awake? First of all, you awake? Also,
I'm awake.
all right.
Come
I
on.
wasn't sure.
As it happens, last year I went through the same thing with my father, who sadly passed away, but he had a full and happy life. And we had what I would describe as a good experience with our oncologist, but there was that moment where my dad asked, so, if everything goes right and if everything goes wrong, how long are we talking about? And he said something like best case scenario, 18 months to 2 years. Worst case scenario, really, 2-3 months. And my dad made a face. Now, my dad, I think, had come to grips with his illness. And so his face was kind of to my mom, almost to say, whoa, we're talking just 2 months. And it turned out it was only something like 3 to 4 months. You must have those moments all the time. And my question is, how do you handle that?
No, that's a very good question. So how I usually handle it is I sort of read the room and I ask the person, do you really want to know the answer to the question?
Yeah.
Especially if there's somebody else in the room, because they might not want to know the answer to the question. And so and you know what? many times people say, you know what, I actually don't want to know.
Hmm.
And I tell people that I'll be honest with them. I said, we'll start the therapy. You're not, if they have, metastatic disease that is not curable, I said, we start the therapy, see how you do. And we're continuing to readdress this. You're not signing up for, X number of treatments. You're going to see how this goes. And then if you respond well, then your time will be longer. If you don't, then I'll be honest with you about how things are going. And then some people say, no, they really want to know. And then I answer them, but I also say, you're an individual person and I'm only giving you averages, right? So I don't know how you're going to do. And people surprise me all the time.
Yep, that's true.
I mean, I've had people walk in with widely metastatic disease and they're asymptomatic. And I'm like, I looked at their scans. How could they be walking in like this? And they do really well. And other people that you think are going to do well, don't do well. And I mean, I'm like only human and I can only tell them averages, but.
And that's it. And I think it's okay to say that to patients too. Like, and honestly, like, again, doing this a long time, it's possible to be honest and still be positive. And, you can tell people the truth. You can tell people some of the truth. You can tell, you know what I mean? But you can tell people what you just said, because that is also the truth. Like, I cannot predict how this will go. Some people live years, some people live months. Let's take it one step at a time. Like, those are things that are not misleading to say. I do feel like sometimes doctors, they lose patience. They can crush people's spirits if they're not careful with how they talk to people. You were wonderful, by the way, with my father about the way you always presented information to him that was honest and factual, but also hopeful. And I thought that was really important for the care that he got. So I've seen you do it, and I've done it myself, and it can be done. It can be done. Awesome.
Yeah, thank you. I mean, I think it's really important to be honest. Obviously, you have to approach it in a sensitive way. But when people say, when I say like it's unlikely for a treatment to work, and they're like, well, you don't sound very hopeful. And I said, no, I wouldn't offer it to you if I wasn't hopeful. But I just want you to understand that, like, what is the likelihood of this working, just so that you're making the best decision for yourself, right? Because it's at a cost of toxicity or whatever, So people have to think about how they want to spend their time, and that's important, I think. So.
Absolutely. All right. Anything else you want to add, Producer Dave, or should we let the doctor go?
I think we can let the doctor go.
Well, listen, this was wonderful. Thank you so much for coming in.
Thanks so much.
Doing this. This was great. You're a terrific oncologist, a terrific person. And my family owes you a debt of gratitude. I'm going to tell you right now, I'm warning you that I'm going to send you email when I have a patient that I know needs to be seen quick, because that's what I do. I advocate for my patients. That's like 80% of my job, is to go to bat for people and help them navigate the system to get what they need, a system that's a total mess. So I do that a lot. So you will get email from me.
No, that's fine. No, I appreciate that. And unfortunately, we have to do that to get things done. We do.
You have to fight for people. Yeah. That's just the reality. And that's what I do in my office a lot. All right. Well, thank you, Dr. DeRose. I appreciate it so much. We'll be in touch and stay good. All right, Producer Dave. Well, that was great, huh?
Fantastic interview
with Dr. DeRose. You can see why she's such a great doctor and a great oncologist, I think, from the interview there.
Absolutely. Just an amazing touch. And, although, we've talked about this and you and I both went through it, incredibly sad thing to go through. It really makes a difference to have someone with the right touch giving you the facts, giving you advice, but also, some sympathy and some empathy. It is important.
Absolutely. And I can tell you, for our family, it was so important. And she was so good about, as much as she's so knowledgeable and she knows what she's doing, and she did a great job from like the medical side of things. She was also great like that. So, for people out there that are struggling with these issues or potential diagnoses, and you're looking for a place, I mean, the Beth Israel Cancer Center in Needham, I just can't say enough about it. And I know my father loved it. He wanted all the donations to go there after he passed. It's a wonderful place. I've sent so many patients there, had great experiences. Full disclosure, my wife and sister also work there as nurses. So, but it's a really great place. Okay, are you ready to move to In the News?
Let's do it.
All right.
In the news.
Okay. In the the news in the world of healthcare and medicine, a few stories you probably saw somewhere on your social media feed that I want to talk about. Number one, producer Dave, U.S. life expectancy hits an all-time high. Did you see this one?
I did not.
Yes. This is from Scientific American, January 29, 2026. Americans are living longer than ever, but still behind the life expectancy of other developed countries. No surprise there. But they do paint an optimistic picture for the life expectancy now of Americans. Going against a trend, the life expectancy has been going down for a long time in this country, probably directly a result of some things like obesity and some of the consequences of that. Care to venture a guess any of the reasons why it might be going back in the other direction, back up?
Well, we're post-COVID. Is that possible?
That's number one.
Okay, is that right?
100%.
Oh, okay.
Yeah. That's on the list. And vaccination against COVID and all that stuff, that made a big difference, whether people want to believe it or not. How about a public health win that you don't hear a lot being talked about, but I think people are going to start to talk about? Substance abuse and opiate epidemic. Less people are dying from that.
Sure.
And those are young people.
And what do you attribute that to? It seems like the awareness has been overwhelming in a good way. You know, there have been documentaries, there have been movies, it just gets talked about a lot more. And I wonder if that, putting it in the limelight.
I can tell you right now, as a physician that's been in practice for like 15 years now, and there is so much more scrutiny on us for the narcotics we hand out now. There was a culture of just like permissibility, I think, when I first came into practice, and doctors were at times reckless with how they handed out these medications. And I think that's totally different now. I can tell you right now, like, we have access to a database. I check every person before I prescribe them, right? I know everywhere that person got a prescription from.
There was call it a boom for all the wrong reasons, I guess. But when the pharmaceutical industry, with the advent of things like OxyContin and the sales staff that the pharma companies put behind these, and in conjunction with, as I understand it anyways, some parts of the country where the rules were such that you could have these, did they call them dispensaries? Essentially, the non-hospitals, non-medical practices where people go and it's through some cockamamie, scheme, get a script and walk out with drugs.
I can just tell you, narcotics for chronic pain is just not something we're really doing a lot of. It's very niche situations right now, which it was not the case 15 years ago at all. So I think that's something that's a big part of it, because a lot of that created the opiate epidemic. I mean, it really did. It started a lot of it in medical offices. That's the unfortunate reality of the situation.
For men, if I've got this right, the life expectancy in the U.S. is 73 to 74?
76.
It's 76 now?
Yeah,
okay. Yeah. Oh, you're right. You're right.
But that's a little misleading too, because remember, that factors in like infant mortality and childhood things that are more, dangerous. So if someone makes it to like 40, right, they're probably going to make it to in the early 80s at least right now. So it's definitely a good thing. But 76 is the overall number, and factoring in everything from childhood and perinatal and all that stuff. And then there's one other reason, and it's going to tie into the next topic. One of my favorite topics we talk about almost every episode, because it's such a huge part of healthcare in this country right now, Ozempic and GLP-1s. These drugs significantly lower cardiovascular disease and death. That's the number one killer. We've got a lot of people now, a 30% reduction in cardiovascular death for high-risk people that take these medicines. I mean, that's making a difference in terms of these very high-risk diabetics and these high-risk people with multiple risk factors that are getting huge cardiovascular benefit. It's, I think, starting to show up in the big epidemiologic population-based data.
You've said it many times. It is not a cosmetic drug. It is not. It is not. Right. Well, it's not only. It's not only a drug to make you look good, look better, and lose weight. It may do that.
Right.
But as you said before, the benefits with the heart and lung safety is huge.
Absolutely. And so let's go to the next story, because the next story is going to be about. We've talked about this before, but it's just such an important story. GLP-1 weight loss drugs help drive another year of historic losses at Blue Cross Blue Shield. Do you remember we talked about this last year?
Absolutely.
And it happened again this year. $300 million, Blue Cross, a $380.5 million operating loss, right? And so why bring this up? Because this is like the contrast, right? You have this terrific drug that's saving lives, that's helping people live longer, and yet you have the coverage being pulled back by all these insurance companies. They have tighter than ever since January 1st in terms of getting these drugs. Why? Because they're money losers. Blue Cross lost almost $400 million. Blue Cross alone, $400 million in Massachusetts last year on Ozempic and Ozempic-like drugs.
Crazy. It'll be interesting to see how it shakes out because, sadly, a lot of people who are reaping the benefits of Ozempic and drugs like it'll be pretty sad to see them have to abandon it.
Yeah, 110%. It would be a terrible thing to see. Did you see? By the way, I know a lot of people probably saw this on Facebook. Did you see the story that went around a few days ago about the 3 deaths that were not reported from Ozempic drug maker?
No.
You didn't see this?
No.
So the FDA gave people a warning to Novo Nordisk because they failed to report deaths of weight loss related drug patients. So 3 people died when they were on Ozempic or Wegovy, and the Novo Nordisk didn't report it to the FDA. And they got a slap on the wrist this week.
Interesting.
Yeah. And just a reminder, and as an aside, none of those deaths we think were actually related to the Ozempic, but they were supposed to have been reported and they weren't. But I think it does bring up the topic, Dave, of as much as I love these drugs and they're great drugs, they're also not without a downside.
Sure.
And I think people need to remember that too, because people, I think, are getting a little reckless with them too. If you're a diabetic, you have a 400% chance of having a stroke or heart attack, dying of a stroke or heart attack than the general population. So, that justifies a little bit of a side effect profile, because if you don't take it, right, you're going to have a much higher risk of having a heart attack or stroke. This can drop that risk by 30-something%. So it's a big deal. But the other side of the coin, we got people taking them because they want to fit in their wedding dress.
Right.
They're 32 years old, their BMI is 25.3, and they're getting it from some pharmacy in Canada or Mexico or something. And that probably is a little excessive too.
Yeah. Well, you're making life decisions about your health. Looking good for your wedding day is important, but let's not couple it with life and death.
Absolutely. Okay, next story in the news. I want to talk about ChatGPT saved my life. This is from NPR, January 30th, 2026. Basically a great article about how patients and doctors are using AI to make diagnoses. What do you think about AI in medicine, Dave? Could you ever see yourself going to a robot doctor?
I ask AI questions all the time that are health related.
Yeah.
And sometimes it's helpful because ChatGPT, but it surprised me one day. I was asking something about my allergies, and ChatGPT said, well, do you remember when you were having that problem with the rash you had about 6 months ago? And it remembered that I had asked it about it, and it was relevant to what I was dealing with. But I would never trust it with a serious health issue because it gets things wrong all the time, blatantly wrong.
Right. Well, even we talk about sports on this. If you ask basic sports information, and sometimes it will come up with things that are totally off the friggin' wall that I know are wrong. Yeah.
Oh, yeah. It'll say things like, well, when Manny Ramirez played for the Montreal Expos, and you'll say, excuse me, are you sure he played for the Expos? And then it'll say, oh, good catch. You're right. I was wrong about that.
Right.
Where did you get it from?
Right. What if he didn't know to ask?
Exactly.
You were wrong, right?
Exactly.
So that's the danger. I will say, I do use a little bit of AI in my practice now as a supplement to what I do, and I find it helpful. And I think it's come a long way. But would I say I'm going to trust it with my life or let someone of my patients trust it with their life? I wouldn't trust a damn thing there outside of the context of a human doctor or healthcare provider interpreting it still for you.
Absolutely.
It's crazy though. And, people get a lot of information. They come to my office with information from AI, and sometimes they still don't know what the hell they're talking about. So
yeah, I feel for you. That there was a depiction of this on the TV show The Pit I think it was last season, but there was a mom of a kid who was being treated, challenging everything the doctor was saying, and she had her phone out and she was just Googling things. Right. And AI is just the latest, incarnation of that. And so I feel for you. People, when you're the one with a medical degree and you're battling with, AI or Google or what have you.
Right. Well, I've always said, Dave, the only thing more dangerous than misinformation is information taken out of context.
Yeah.
And that's the reality. And when people go on AI and they ask questions and they don't know really what the information they're getting back is or how to interpret those facts, that can be dangerous. All right, next one. Is that carb ultra processed? Here's a test even a kid can do. This is from NPR from a few weeks ago. And one of the things that has happened with RFK, you know, a broken clock being right twice a day, if you will, is that one of the things he's right about is urging people to avoid highly processed foods. It's really been a huge failure of our healthcare system. The fact that that we haven't really taught people how to know a good carb from a bad carb. So let me ask you, do you know how to tell a good carb from a bad carb, Producer Dave?
I don't think so, but I know certain things that could make certain educated guesses. For example, I would say something like wheat bread is probably more of a good carb than a bad carb. A banana maybe is more of a good carb than a bad carb. Am I getting close? No? Sort of. So there's a lot of misconception. Oatmeal.
So you ever heard of something called the glycemic load?
No.
Okay, this is like really important. Everyone should know this. This is where we failed as a public health system, right? The glycemic load is a measure of how much different foods spike your blood sugar once you eat them. And foods that are high glycemic are really bad for you. Foods that are lower glycemic are better for you because they don't spike glucose and they don't spike insulin. You take the same carbohydrate, right? You take an apple, you eat the apple, it's low glycemic, right? All the fiber in the apple slows the absorption of the sugar and your glycemic response, your sugar response is nice and level. Take the same apple, put it in a blender, turn it into apple juice, right? Now it becomes high glycemic. So it's not always about the food itself, but oftentimes how it's processed.
Wow.
And that's why we talk about processed foods as being so dangerous. So processed foods are going to send your blood sugar on a roller coaster ride. And in case you haven't noticed, unfortunately, we have developed a food system based on ultra-refined grain. And most Americans don't have a clue about what is a good carbohydrate versus a bad carbohydrate. So what this article says is a test, right? It's called the water test. Take the starchy food, put it in water, and see what happens in 3 or 4 hours. If it breaks up, then it's probably high glycemic, easy to digest, and that's the ones you should stay away from.
Good to know.
Yeah, we could do a whole episode on this. In fact, we should do a whole episode on like carbs, and I could bring in some samples and, you know, at the grocery store, what to look for. But you want to learn about the glycemic. If you're a diabetic, you have blood sugar issues, learn about the glycemic load, learn what it means, find those foods that are low glycemic and stick to them. You know, carbs are not bad for you as long as they don't spike your blood sugar. So that's what we all need to learn. Okay, Producer Dave, anything else?
No.
Okay, let's move on to the best part of the show every week, the non-medical topic of the week.
The doc is off the clock, so it's time for the non-medical topic of the week.
All right. I am so off the clock. The pager is in the trash. I'm sleeping in a closet, and don't bother me. But here we are. We're in the non-medical topic of the week. I want to talk about a few things this week. Number one, it is March Madness. We're recording on the first day of March Madness. So I want to ask you, Producer Dave, did you do a bracket? And what is your general thought about March Madness brackets?
It's always fun. I wish I had, this is going to sound weird, I guess. I wish I had more time to spend on it. I did do 2 brackets. I kind of did it kind of slapdash. There are a lot of guesses in there. I try to avoid having complete chalk, like, you know, having, you know, the 4 number 1 seeds in the final 4, because what fun
poison.
Is that?
That never happens.
And it happened once or twice, but usually it doesn't. Even if it does happen, what fun is doing that? And I always lose, like everyone else, you know. I mean, you can't expect to win. Somebody random wins that knows nothing about basketball, but it's always fun.
There's always that like one person in like, you know, Nebraska that has like the perfect bracket. It's like, how do you do it? Yeah, I did one this year. I don't know anything about college basketball. I used to know so much more about it when I was younger. And it's just like, I don't know. I stopped watching it. I mean, I feel like maybe we're paying less attention to it now than we used to, just general as a sporting public.
Well, when we were younger, I'm older than you, of course, Dennis, but it was college basketball was easier to follow in a sense because players stayed 4 years.
Right.
You know, or at least 3 years. And now the one and done is so rampant that, you know, I can't name I don't think I can name one player in college basketball right now.
You're right.
So
when you do the bracket, you're basically like, the 6-year-old picking horses at the track based on the name they like, right?
Yep.
And that's what it's become. I will also say, just as a general thought about brackets, and just as a public service announcement to the world, nobody cares about your bracket. Please don't talk to anyone. No one cares. It's like your fantasy team.
Right.
Nobody wants to hear about your tight ends. No one wants to hear about your receivers. Nobody wants to hear about your bracket. Enjoy it. Appreciate it for what it is. Love it. It brings you joy. It brings you entertainment. It's gambling. It's fun. Whatever. All good. Go for it. Just don't talk about it.
Yeah. As we were recording this episode at the beginning, Dennis, Duke trailed number 16 seed Siena by as many as 10 points.
Oh.
And I was watching it. There's 2 minutes left. Duke leads by 4. They're not going to lose.
They're not going to lose. Yeah. And that's the thing. You're just rooting. Obviously, you're rooting against Duke. Everyone's rooting against Duke.
Right.
Yeah, Duke is easy to root against. Let's face it.
True.
All right. Number 2 non-medicine topic of the week. This week was St. Patty's Day. You St. Patty's guy, Dave? Did you go out for St. Patty's Day this year?
I didn't go out for it. I am half Irish. I'm half Irish, half Jewish, and I'm bad at both of them, I think. But I like the traditions. If someone invited me to go to St. Patrick's Day festival, I would go.
You a corned beef and cabbage guy?
No, that's horrible food.
Horrible.
My mom made it a couple times. My mom is in O'Neill. She grew up in Irish Catholic family. Nothing they cook was very good, to be honest. Sorry, Mom.
Yeah, I mean, it's one of those things that even once a year might be too much.
Yeah.
Honestly. I will say, just as an aside, the Simpsons episode for St. Patrick's Day, you know which one I'm talking about?
Is it the one where the TV announcer says,
yeah,
drunkenness, fighting, and general rowdiness? Is this what St. Patrick's Day is?
Yep. One of the all-time great Simpsons episodes.
They nailed it.
One of the all-time great St. Patty's Day episodes. The beer baron in the Prohibition.
Yeah.
That's absolute classic.
Yep.
And then, all right. I think I had another one, but I know we're running short on time. So let's go to the Boston Sports Minute, and we'll save the cover song better than the original. We'll save that one for next time.
That's a great topic. We'll do it next.
It deserves like at least 5 to 10 minutes on its own, I feel like. I don't want to cram that in.
It's the Garden. It's Teddy Ballgame. Yaz and Poppy and Noma. It's Brady and Larry and number 4 Bobby Orr. It's Fenway Park. It's the Boston Sports Minute. Let's go.
Well, we got a lot going on in the world of Boston sports, producer Dave. I don't know where you want to start. You pick. Celtics, Bruins, Red Sox, Pats. We can talk about everyone.
I'm still obsessed with the Pats. We talked about the obviously the results of the Super Bowl was a bummer, but I'm watching it intently. I like this Romeo Doubs wide receiver they got.
Love it.
I do want them to get one more. The kid, who's the guy we want?
AJ Brown.
AJ Brown. Now it's like he's the white whale. He's not Randy Moss. He's very good. We do need yes, we'll be a lot better with him. But in the event we don't get him, I guess I'm not going to be crushed. What about you?
Look, where there's smoke, there's fire, and there's a lot of smoke around AJ Brown's knee.
Yeah,
and he hasn't gotten traded yet for a reason, and it's because his knee is not 100%. There's something to that, and that's why I think this hasn't happened yet. Why the Patriots don't want to give a first-round pick, and why the Eagles can't seem to find another partner to trade with. Look, I'm okay without AJ Brown. I'm not overpaying for a 29-year-old receiver. He's been in the league for 8 years. This will be his 9th. He's got a ton of miles. He's got a bum knee, and he's kind of a diva. If they got him, I'd be happy, but for the right price. It has to be for the right price. I'm not giving up huge draft capital. Totally okay if they don't bring in AJ Brown.
I want Vrabel to do what Belichick did at his finest moments, and that is, yes, occasionally you would get the Randy Moss or the Wes Welker, and you can celebrate your shiny new toy, but usually it's a bunch of moves with guys we've never heard of before, and just quality guys, try to build a culture. It feels like that's what Vrabel is doing. He certainly did it last year, and I hope he takes another step further. So, like a few of these little pieces they've gotten, I hadn't heard of the guys, but when you look into it, it's like, hey.
Yeah, I do love the way they kind of built this roster this offseason. And when people were saying, oh, they're not going to do anything in free agency, I mean, they did a lot. They did a lot. And I think
few important ones,
for the first time in a long time, they go into this draft where they don't have to draft to need. They can draft whoever they want in this draft, and they're kind of in okay shape.
Yeah, I agree.
Awesome. All right, and then quick thought: Celtics, Bruins, Red Sox. What do you got? We got a minute.
not a huge hockey guy, as you know. Excited for the Celtics. I thought this was going to be a down year like everybody else.
Yeah.
Jaylen Brown's the real deal. It's going to be exciting, and I don't like the naysayers who say, "Oh, I don't know how Jason Tatum's going to fit in now." Right. Fit in? The guy, the guy's a borderline MVP. He's one of the best players in the league. You're getting him back. It's huge.
I've been impressed with how he's looked.
Yeah.
See, before the season started, I almost put $100 on the Celtics to win the title because I knew Tatum would be back. I mean, I just knew it because he's young, he's healthy, and having been a doctor for a long time, it matters when someone wants to come back, when someone really is willing to work through pain and fight through pain. And Jason Tatum loves basketball, so I knew he'd be back. And I think they're in great position.
Sure.
And then I'll give you one quick Red Sox take.
Go.
Love this team. They're going to be good this year.
Really? Okay. You think so?
Yes. Contreras is going to fill the hole that Bregman left. I don't think Bregman had a great year. Let's not overstate what he was. He was a leader, but there's more than one way to skin a cat. There are other guys in the locker room that will step up. The pitching's terrific. I think Roman Anthony takes a step up. Contreras will produce at least as well as Bregman did. And I just think they're filled. They still got some pop in that lineup with Abreu and some of the other guys. I think they're going to be at least a division contender.
And they've still got this cadre of young players that made the team relevant last year.
Totally.
And why can't, second and third year players and guys like Rafaela, Anthony's the one that everybody's most excited about, but we got a few others in there. And you're right, pitching is king, and their pitching looks solid. I've seen their pitching ranked among like the third best rotation in the majors. So.
They have great pitching, and last year one of their big issues was their 4 and 5 starter, and that's not going to be an issue this year. They got depth. So, it should be a good year. I'm pumped for baseball season.
Go Sox.
Go Sox. All right, man. Anything else before we wrap it up?
That's all I got, Doc.
Awesome, man. Well, listen, thank you to everyone that listened. Please find us on Facebook, Instagram, YouTube. Subscribe to our channel. Keep supporting us, and we'll keep producing awesome content. Hope you enjoyed this episode. Take care, everyone. Be healthy, be well, be safe, and catch you next month with another episode of the Modern Medicine Podcast.